This is the session from the bench to the patient side, the ALFASIGMA session. We would like to welcome you all. I would like to also welcome and call upon all the moderators. So myself, Al-Mamoun Jastaniya, interventional radiologist from Saudi Arabia, and then Dr. Bettini, Dr. Olarius from Romania, Dr. Lazarashvili from Georgia, and Dr. Rial from Spain. We would like to start our session and then with the first talk. So a few housekeeping points. We will have a dedicated time for questions. So we'll start the session, we'll run through it, and then at the time of the questions, we'll take it from there. So the first speaker is going to be Dr. Orbanik from Poland, who's going to talk to us about solid dioxide, what is it, what it does, and indications. So Dr. Orbanik, please.
Good morning. Thank you for invitation. So the excite, what is it, what it does, and also some words about indications. So first question, of course, what is it? I think that most of that Sudexite is a glycosaminoglycan, which is the combination of fast-moving heparin, 80%, and 20% of dermatan sulfate. And Sudexite has the unique affinity to the surface of endothelium, and this is rather than to the plasma protein. That's why we do not observe in the global coagulation test the effects of anticoagulation effect of Sudexite. What it does, Sudexite restores Glycocalyx. It has very pluripotential activity. Glycocalyx has multiple roles: control of vascular tone, response to shear stress, regulation of permeability, inhibition of complement activity, and also interaction with leukocyte and platelets. And the surface of glycocalyx has antithrombotic and pro-fibrinolytic properties. What it does, speaking about the biological effects, we should mention reduction of venous and arterial thrombogenesis, anti-inflammatory effects, and also endothelial protective effect. We know that inflammation is crucial in chronic venous disease development and progression, and from several studies done in vitro and in vivo models, we know that Sudexite has the potential anti-inflammatory activities, at least in chronic venous disease patients. Sudexite biological effects can concern also combined anti-atherosclerotic and antithrombotic activity, especially in patients with dyslipidemia, diabetes, and metabolic syndrome. One of these properties is the lowering of the VLDL level and increase of the HDL level via the release of lipoprotein lipase. According to the recent studies, Sudexite enhances also contraction in veins and induces arterial relaxation. This one is related to release of the nitric oxide. When it's used in several vein disease, arterial system, and microcirculation disorders indications, if we speak about the chronic venous disease symptoms and sign, as documented in the systemic review and meta-analysis of Professor Biamini, a significant reduction of the several symptoms and signs related to chronic venous disease can be observed in patients treated by Sudexite. Sudexite reduces also the chronic venous disease-related swelling, and this effect is dose-dependent. It works in C6 patients, so having the special impacts on several biomarkers of inflammation and granulation phase of this chronic wound healing. And from the randomized control studies, we know that this results in the improvements in the clinical efficacy and higher number of the completely healed ulcer when treated with Sudexite plus the standard therapy. In chronic venous disease patient, we can also expect the lipodermatosclerosis area reduction when treated by Sudexite. And recently we started to use Sudexite in periprocedural treatment to reduce the hyperpigmentation rate in the patient undergoing sclerotherapy. And this was documented in this study coming from Mexico in 1 and 3 months observation. Venous thromboembolism recurrence prevention, another interesting area. We know that in many patients, after at least 3 months of therapeutic anticoagulation, we have to continue the antithrombotic treatment. We can do this with full anticoagulation, with reduced doses of anticoagulants, but we can use also sulodexide. After the SURVET trial, we know that when using sulodexide after therapeutic anticoagulation in the 2 years of the sulodexide therapy group, when compared to the placebo group, the significant reduction in the recurrent VT was observed, which was significantly lower in the patient treated with sulodexide. This indication we can find now in some guidelines like European Society for Cardiology guidelines from 2019 and the European Venous Forum guidelines published in 2020, where we also see sulodexide in this indication. Post-thrombotic syndrome, another important area. We know that the symptoms are related to secondary venous hypertension, which can be related to reflux, obstruction, or both. And the important part of this process is, of course, the inflammation presence. This inflammation can be present locally around the vein, inside the vein, but also in the soft tissue of the lower leg, which is related to secondary venous hypertension. And from this study, we know that sulodexide can reduce the chronic venous disease symptoms in post-thrombotic limbs. Moreover, this drug has also potential to prevent post-thrombotic syndrome occurrence. And in this study, comparing the patients treated after therapeutic anticoagulation in 3 groups, no treatment, sulodexide or aspirin, the lowest rate of post-thrombotic syndrome was observed in patients treated by sulodexide. Arterial indications, this is the meta-analysis of the trial of the patients treated by sulodexide versus placebo or versus pentoxifylline in the group of the peripheral atherosclerotic obliterative disease. And according to this meta-analysis result, the administration of sulodexide in the dose 60 to 100 milligram per day for 3 months significantly increases initial claudication distance in the patient stage 2 Fontaine classification. We have also the very promising result that sulodexide increased the claudication distance in patients with diabetic peripheral arterial disease, increasing the pain-free walking distance or increasing the maximum walking distance. According to the Professor Biamini meta-analysis and this 2 trials, we know that sulodexide can improve the healing of the diabetes-associated trophic ulcers. And recently also some of the physicians started to use sulodexide on the top of the standard therapy in the patient undergoing angioplasty due to critical ischemia related to the diabetes. And according to this study, adding sulodexide reduce more rapidly pain intensity and increase the TCPO2. But also has some influence on the plasma parameters with plasma fibrinogen and C-reactive protein concentration reduction. Diabetic nephropathy, one more important indication. We know that these patients are very problematic and difficult to treat. Sulodexide, according to this meta-analysis, as well as the number of performed studies, can decrease the urinary albumin excretion, and this concerns both situation, patients with micro and patients with macro albuminuria. Diabetic retinopathy is one of the very important indications to use sulodexide. This disease leads to the subsequent visual loss due to occurrence of the hemorrhages, heart exudates, macular edema, and retinal detachment. And we know that using oral sulodexide over 12 months improved the macular heart exudates in patients with mild to moderate non-proliferative diabetic retinopathy. Moreover, this happens without detectable adverse events. What else? One more study, I think very, very important. It's analysis of 6 randomized controlled trials, more than 7,000 patients reporting cardiovascular outcomes in patients receiving Srodexide versus controls. Special patients enrolled with different indication, post-acute myocardial infarction, PLD, with stable claudication, secondary VT prevention, type 2 diabetes with macroalbuminuria, and the use of Srodexide in this special population was associated with reduced odds ratio for all-cause mortality, cardiovascular mortality, myocardial infarction, and VT occurrence. So it seems that this drug has also a very systemic effect, which seems to be important in terms of major cardiovascular events reduction. Thank you very much for your attention.
Thank you for this kind invitation to present in this session the topic about the current evidence of the medical treatment on chronic venous disease. As background, I'd like to emphasize that chronic venous disease, as we know, are among the most frequent diseases worldwide, with varicose veins present in 25 to 40% of adult populations, and chronic venous insufficiency C3 to C6 with a prevalence of around 17% according to different epidemiological studies. We also know that it is a progressive disease, and according to the Edinburgh study results, progresses in more than 50% of the patients in a follow-up period of 13 years. And reading the latest European Venous Forum guidelines that were published in 2018, in the options for management of patients from the early stages of chronic venous disease, the vein-active drugs may be used also in conjunction with interventional treatments of risk such as sclerotherapy, surgery, and endovenous. We are aware that the objectives of the management from the early stages of chronic venous disease includes to alleviate venous symptoms and signs, to break the inflammatory cascade, and to prevent the progression into higher CIP clinical class. But for this, it is crucial to understand the pathophysiology of the disease. Beyond the biomechanical forces, we have to include in this equation the huge importance of the cellular and molecular influence, and in particular at the endothelium. It is well established in the literature the importance of the leukocyte adhesion, the interaction with the endothelium, and the release of the inflammatory mediators. In fact, the varicose veins are a complex disease with multifactorial pathogenesis, and we should include the importance of hemodynamic factors, the local hypoxia, the dysregulated apoptosis, alterations in extracellular matrix, the genetic predisposition, and the environmental and patient factors. Trying to summarize all these pathophysiological mechanisms of chronic venous disease, we must be aware of this vicious cycle with venous hypertension, the leukocyte adhesion, the interaction with the endothelium, the release of inflammatory mediators, and at baseline, the concept of specific venous chronic inflammation. And most probably, this release of inflammatory mediators is the responsible for the activation of C fibers nociceptors, and in consequence the production of symptoms. And these symptoms are diffuse and pleasant with a significant impact on the quality of life. Having this in mind, you can find here in this table a resume of the different pharmacological actions and proven clinical benefits that we can find in the literature for each specific venoactive drug available in the market. Having this in mind, it was recently published an overview of the use of sulodexide in venous disease and its various biological effects, including antithrombotic, anti-inflammatory, and endothelial protective with the restoration of Glycocalyx. Even more recently, it was published in this first systematic review and meta-analysis of the use of sulodexide for chronic venous disease, including in this table the effect on the symptoms and signs like pain, cramps, paresthesia, heaviness, edema, discoloration, or skin temperature. In the same publication, it is also possible to read and analyze the effect of sulodexide on the release of the inflammatory markers in chronic venous disease, and also the extremely low incidence of patients with chronic venous disease reporting adverse events during this treatment with sulodexide. In more advanced stages of the SIB classification, we can read in the latest European Venous Forum guidelines published in the International Angiology Journal and also endorsed by the International Union of Angiology and the International Union of Phlebology, we can read that as an adjunctive of healing of leg ulcers, the sulodexide, pentoxifylline, and MPFF has obtained a grade A of recommendation. As my take-home messages, I would like to emphasize that taking in account the current demographic characteristics of the Western world, with an aging population and an ongoing obesity epidemic, it is more than predictable that the prevalence of chronic venous disease will rise. Also, to highlight the chronic inflammation as a key role on the pathophysiology of primary chronic venous disease, that in our daily practice, venous symptoms are still underestimated and undertreated by us clinicians and by the patients, and they have a significant impact on the quality of life of the patients. Thank you for your attention.
In our country, in Turkey, we are very lucky. The reason is we have the facility to have all of these drugs under government payment. We got all of them, and what I can say you is definitely for symptom relief, all of the venoactive drugs are working very well. We have been using all of them for 20-25 years, and recently we started to have sulodexide as well. Sulodexide is an old drug, not a new one, but because of some reimbursement issues, we have this one. Interestingly, in the COVID period, specifically in the COVID period, I don't know why, we have to research it, and specifically for post-DVT patients, after the DVT treatment, sulodexide did a wonderful job. Definitely, it's different than the other venoactive drugs, And specifically in the COVID period, we were very happy to use silodoxide in the post-COVID DVT patients, definitely after anticoagulation treatment. Thanks a lot for the opportunity.
Next expert, Professor Shaidakov from Russia. Evgeny, please.
Dear Zaza, dear colleagues, dear friends, I don't know Armando is online or not, but I wrote some remarks for his presentation. It's a very, very important topic. So 2 remarks. The first one, we know about the works of Joseph Raffetta. He opened this Glycocalyx discussion, and we know about his works, but very important about the function or dysfunction of endothelium. Glycocalyx is well-known layer of micromolecule attached to endothelial cell membrane. It has multiple important functions. It is transport mesh for different molecules, its anticoagulant properties, and it's an important component of cell-cell interaction of the surface of endothelium. Destruction of glycocalyx may be one of these first things of endothelial dysfunction or injury that leads to form of nanoparticles of glycocalyx that may have various biological effects. Studying nanoparticles of glycocalyx today, we could promote early diagnostic of chronic venous disease. And the question to Armando, which may lead us to novel early pharmacotherapy. And another remark, there is no doubt that venous thrombosis remains the quicksand of modern clinical medicine. Balancing between the risk of recurrent thrombosis and the risk of bleeding with anticoagulant therapy, we always look for an individual approach to each patient. In oncological and general surgical patient or patient with trauma, the selection of anticoagulant therapy depends on a great number of factors. Solid exercise has been proven to be extremely effective in protection the endothelium. And considering the known causes of thrombosis in patients receiving chemotherapy and immunotherapy, can thrombosis be prevented the rational prescription of solid oxide alone? It's a very important question. We would like this year start this program and to investigate the glycocalyx function in patient of oncology profile during the chemotherapy and immunotherapy, and try to prevent the venous thromboembolism of this kind of patients with solid oxides. It's very important, and I invite all of you to support this program. Thank you very much.
Thank you very much, Evgeny. Is Dr. Zini here? Okay, please, your comment.
Thank you. My one is not a comment, but is a question to you and to the public here. We all know the use of sulodexide in thrombosis, superficial phlebitis, and chronic venous insufficiency. Do you think there is any indication of using sulodexide in the post-operative period? I mean, after surgery, after laser, after radiofrequency, and also after sclerotherapy.
It's very great, very big question,
Yeah.
and it's very disputable. From somebody want to, from audience or my colleagues, comment?
Is there any papers in the literature about that?
Yeah, I don't remember any paper literature in which the using of the sulodexide after the surgery, except the surgery except the treatment of venous ulcers, because we all know that sulodexide have the great positive influence in the treatment of patients with C6 chronic venous disease. But using after the laser treatment, there's I not remember maybe, but there is no some significant data about this type of indication. Maybe my colleagues have some comments about this. Maybe you remember some study, or it's very interesting idea, but we need, and maybe it will be some basic for future studies, but not now. Now I don't know using of sulodexide after the laser or the surgical treatment.
The question directly to the inflammation we have, the thrombosis we have after treatment.
Yeah.
So it can be useful.
Yeah, please.
Hello, I'm Alejandro Gonzalez. I'm from Mexico. We did a study using sulodexide in sclerotherapy. We used it before starting the treatment. We did 600 patients. It was published in the Journal of Venous and Lymphatics in early in 2021. And we did had a good result. The focus on the study was preventing hyperpigmentation. And regarding the inflammation and the presence of thrombosis as a risk factor for this. And using sulodexide, we did have a benefit. It doesn't prevent all of the pigmentation, but it did reduce the incidence of it. So this is that we had.
But this is your personal experience, yeah?
It was a randomized prospective study in 5 centers in Mexico.
Oh, it's very interesting. Okay, thank you very much. And now maybe you introduce the next speaker.
Yeah, no, question about from the audience. Any question? Any comments? Well, about the experience, and we were increase our confidence in this drug sulodexide more and more during these years, and think it has a long run in the future, trying to get new evidence in not also in venous disease, also in arterial disease, and probably its thrombotic effects and also anti-inflammatory effect on the endothelium will be the most important fact in this drug.
Welcome everybody again to the Winter Dubai. In this talk we are going to touch some hot topics like the potential antagonism between venous active drugs and graduated compression stockings, and the potential not so much involvement of the arterial side into the venous side and vice versa. These are my conflicts of interest to declare. While I declare that in reality, this is maybe fake news. These opposition between venous active drugs and graduated compression stockings maybe is not really there. And at the same time, this separation between the venous and arterial field is not so much there. Let me tell you what I mean by this, starting with a cinematographic metaphor that is the one of Rocky, when Rocky and Apollo were opponents, and then they understood that they better be together to win, in this case, the championship in benefit of the patient. On one side, we know that proper graduated compression stockings can provide significant benefits in terms of counteraction of venous hypertension, promotion of venous return, improvement of calf performance, improvement also of the lymphatic return with also a microcirculatory action, an anti-inflammatory reaction, and potentially also an increase in tissue oxygenation. On the other side, if we are focusing in this ALFASIGMA session on sudodexide, we know by Mansilla revision of the literature that sudodexide indeed can reduce the peripheral venous pressure, can improve the symptoms and the quality of life of chronic venous disease patients, and it's clearly evident the role in the improvement of ulcer healing. But even more, outstanding papers like the one of Professor Raffetto from Harvard showed how sudodexide may increase the venous tone and far more. And indeed, if we focus on the role of the glycocalyx, and we know that sudodexide is acting on the restoration, basically, of the glycocalyx, we understand the endothelial protection effect we can get. In order to make it simple, we have to imagine the glycocalyx like a forest protecting the soil, like a sort of protection that is all around the endothelial layer, that is in this way translating also mechanical forces into biochemical messages. What I mean by this is that glycocalyx not only is a forest, but it's also an antenna sensitive to the different frictions and shear stress that are acting on the endothelium lining. And this is indeed in the good memory of Professor Lazarashvili, who I'd like to deeply thank for being with us today in Dubai, because indeed it really reminds me of the Georgia Broadcasting Tower, the main tower of Georgia that is sending signals to all the country. Now the country here is the endothelial cells, is the wall of the vessel. And to really remember what the glycocalyx does, I usually think about the PC acronym, so the computer. Because indeed the glycocalyx gives protection to the endothelial layer, it regulates its permeability, at the same time regulates the contractility, as we have seen by the previous publication, and also balance the coagulation. So PC, protection, permeability, contractility, and coagulation. But even more, in this mechanotransduction of physical signals into biochemical signals, we understand the importance of the protection of the glycocalyx when we read papers like this showing how already in C0S we have a progressive loss of the function capillary density, for which the disease starts very early, and whatever can protect against this or restore against the arrangement of the physical forces on the endothelium layer is beneficial, and that it is indeed one of the functions of sudodexide, together with the antithrombotic properties that I think are particularly important nowadays that we are facing with COVID and increase the risk of thrombosis. What I mean by this in the venous field is in particular the periprocedural management. Now we know that venous inflammation is associated with an increased risk of thrombosis in varicose veins patients. You see over here clearly with the Chang paper, 5.3 of increased risk. And we know at the same time that all around the world our colleagues are a little bit heterogeneous, I would say, just to be kind, because it's far more than a little bit heterogeneous in the practice of the periprocedural thrombotic risk management. You see, for example, how in Ireland, 73.3% of the colleagues are always prescribing thromboprophylaxis after chronic venous disease procedures, like varicose veins procedures in general. But as you can see, 71.4% is using one single shot of heparin. That is against the t-shirts we are now wearing at the Winter Dubai meeting, talking about the importance of the Caprini score and the proper risk assessment. Now, a molecule like the one of sudodexide that clearly demonstrated antithrombotic action, anti-inflammatory action, and endothelial protective action could find a role in this periprocedural thrombotic management, particularly in a COVID time, as I was saying, in which our patient can come to our office with a PCR that is negative, do the procedure, and then go back home, meeting family members, becoming positive asymptomatic, increasing the risk. So I have to confess that in this particular COVID time, I am more generous in the coverage of the potential inflammatory and related thrombotic risks, because also we have papers like these ones showing how we have an increased risk of thrombosis up to 10 times higher, not just for a few days, but up to 6 weeks in day hospital procedures, and indeed the varicose veins procedures is the one of the day hospital. Even more interestingly, in this debate about arterial and venous components, the role of the pseudodexide demonstrated that the same molecule can act both on the arterial and the venous side, and in the different aspects also of the inflammatory process of the thrombotic. You see over here, all causes mortality, cardiovascular mortality, myocardial infarction, stroke, venous thromboembolism, with a low risk of bleeding, with the consequent benefit toward the use of pseudodexide, for which we look forward for the results of the step-ahead study that we are conducting at the University of Ferrara, looking forward to understand if pseudodexide can be an alternative to heparin in specific cases of periprocedural thromboprophylaxis, also considering the advantage of the orally bioavailability, of the longer half-life, and the smaller effect on systemic clotting and bleeding. If we go back to the guidelines, we see clearly the role of the extended therapy in different conditions of DVT risk, as you can see here. In the yellow, you can find encircled how pseudodexide is positioning itself in the three different DVT risk classes, with the benefit also of having a low bleeding risk, as I was saying. So it's a molecule that for sure we have to know more and more in our everyday practice, because it can become extremely useful. But independently by the thrombotic aspects, the recently published European Society of Vascular Surgery guidelines, and I deeply thank ESPS for being with us today here in Dubai. Indeed, we see that pseudodexide position itself also in the control of the different symptoms associated with chronic venous disease, and we know already about, of course, all the signs and the role in ulceration. Moving forward in these guidelines of the SPS, we see that we are talking about the different venous active drugs, and I'd like to stress once again the importance of what we did in the winter 2019 document on the different similarities and controversies in global guidelines, because indeed it is fundamental to stop putting together all the venous active drugs as recommendations, but focusing on the different specific features of the drug based on the evidence we have in our hands. And this is true also when we add, for example, pseudodexide to the standard of care, that is compression after sclerotherapy, demonstrating the role of the drug as an anti-inflammatory product that is indeed translated clinically into a decrease of the hyperpigmentation associated with the process of sclerotherapy. That is indeed adding something to what we already knew in terms of compression, giving a benefit in aesthetic sclerotherapy. But what about arteries, since we're talking about veins and arteries in these topics? Well, we have data showing clearly how we can improve the walking distance in peripheral arterial disease patients, and therefore also the quality of life, by the use of pseudodexide. At the same time, if we're talking about compression arterial, isn't it a contraindication according to the general believing? Well, this is another kind of fake news, because we know we can create, of course, complications if we are using the wrong compression, but we also know that we can have significant benefits if we use the proper compression. We can indeed manage the concomitant chronic venous disease, we can heal the mixed ulcers, we can manage the edema, we can help the recovery after surgical intervention in arterial patients, and we can even improve the tissue perfusions, as we will see in a little while in this presentation. But first of all, we have not to forget the coexistence of arterial and venous disease in the same patients. This is a recent publication showing something quite shocking to me. There were signs of chronic venous insufficiencies in 21% of peripheral arterial disease patients. This means 1 out of 5 patients having peripheral arterial disease is also presenting some form of chronic venous disease. The problem is that less than 1 out of 5, only 18% of these people were actually recognized. So you understand how many of these subjects are not properly treated, and are just treated for the arterial part or just for the venous part, without taking into consideration the management of both, as we could do with proper compression, as per this publication that demonstrated that proper compression does not reduce the microperfusion, actually can improve in specific locations of the limb perfusion, with the results that have been assessed in the different positions of the human body, so to make sure that the perfusion is maintained. But if you're talking about arteries, we should talk also about veins and about the lymphatics. As I was saying, indeed, the three things are all together, as we know. In particular, veins and lymphatics, as per the publication of Parsh and Lee, must be considered together as a family affair, as per the title of that publication. Now, I cannot be more honored in presenting today what is, up to our knowledge, the first in-human picture reporting the existence of a glycocalyx also into the lymphatic endothelium. This is a picture we took at the University of Ferrara, for which I deeply thank all our basic science lab representatives, that indeed is answering to a question we had. If we have the glycocalyx on the arteries and veins, and indeed sudodexide can act on them, what about the lymphatics? But are we sure we are looking at the glycocalyx, since we have this electronic microscopy image that was showing that? For that, we ran also immunohistochemistry, and I'm more than happy to tell you that indeed it is glycocalyx with components like a glypican that we have already investigated and determined, and others that we will present shortly in another meeting. So there is a glycocalyx also in the lymphatics, and this could be a common denominator in the mechanotransduction forces translation into biochemical messages, where the sudodexide could indeed have a role, for which we really must think more about this drug, study more the pathophysiology related to its action, so that we can improve more the benefit for our patients. So looking forward for brainstorming together in another meeting how a physical force is translated into a biochemical messages and how sudodexide can help in this. I deeply thank you, and I invite you to the Italy 2023 meeting. Thank you.
And we started the discussion, and the first expert is Dr. Munoa.
Yeah, he's here.
Yeah.
How's that?
Thank you for all the audience. Thank you, Sergio, for the opportunity to talk about this very interesting fields, because the sudodexide show us in the Venous field that have a problem in CBD and have opportunity to treatment in DVT2. But when in the pharmacology, there are a field that we need to research more, that is in the arterial disease, because the glucocalyx and the endothelium and all the products in the oxidonitric in this area could be, they have the benefits of the compressions in the patient that they are the patient with diabetic or with arterial disease, and is contraindication the compression. We in Mexico, we are in Mexico like Alejandro, we use the Wi-Fi classification for try to show out the arterial disease, and we have the contraindication to use compression in Yao index less to 0.8. No? For us, this is absolutely contraindication of the compression. But the sudodexide, in this have opportunity to, in research, show us the possibility to have better wound healing in patients with arterial disease. Thank you for the opportunity.
Thanks to you. I think the interesting part of this drug is forcing us to think about the pathophysiological mechanisms that are in the same side of arteries and veins and lymphatics, particularly in terms of mechanotransduction, which I'm particularly passionate about. So how a physical force is translated into a biochemical message. And therefore, I think that independently by the drug, the important part is understanding how to manage at best the patients who are having at the same time, for example, a peripheral arterial disease and a venous disease, or they have lymphatic disease and at the same time venous disease. That's why I think it's interesting what we reported with the glycocalyx, and particularly in these days of thrombotic risk, the antithrombotic component could, I think, help. And from Mexico, you produce very, very interesting data that are pioneering. So congratulations to Mexico.
Nice comment, great. So we'll ask for Dr. Redman from South Africa.
She's in connection from Zoom, so they should let us know if they are able to have her with us. So meanwhile, just let us know if she's there, and then you...
Then we can go to Dr. Zielinski from Poland.
Adam. That's easy, a little bit easier. Just, yeah.
I'm happy to be here with you. So many interesting points were reached here in your presentation and in the previous talks. So let just me summarize my thoughts about sudodexide and your thoughts. I think that there's a very important thing to, you mentioned that sudodexide starts from the pathomechanism, pathophysiology. It starts from the glycocalyx, from the inside of the vessel, because we have some evidence that it can promote the glycocalyx restoration. We conducted some study in patients with chronic venous disease before and after sulodexide treatment for three months, taking some parts of veins before the procedure, before a small venous procedure, and after. And we showed in electron microscopy that in some parts of venous veins which were suffering from chronic venous disease, the glycocalyx was not so thick, and after treatment it could be a little bit richer and more homogeneous. So I think that's why on the paths we should go and try to maybe to plan some trials. I think the other thought about the antithrombotic therapy and used any drugs, I mean low molecular heparin or DOACs or sulodexide, is that we should really have a plan how to plan trials about this issue, because the discussion about thromboprophylaxis, about especially small many invasive procedures, has been going through 5 years at least. And we know that in the States, all over the world, the policy is different. In the States, they do not use almost any drugs after endovenous laser or some mini invasive therapy. There is, you mentioned Irish survey, which showed that there is a very big diversity in the treatment. So I think that there is a very nice meeting here, maybe to start thinking in realistic, to plan some, to create some maybe international survey, and then maybe the trial about this issue. I mean the thromboprophylaxis after many invasive vein procedures.
I'm extremely passionate, and thank you so much, Adam. And by the way, thank you so much for having brought here the European Society of Vascular Surgery. So really grateful for that. Well, I think that going back always to Caprini and the score, I don't know in this moment if I'm over scoring or not my patients, because they always assume that they come to my office or to the university to do the procedure as a PCR negative, but then they go home the night, they celebrate with the family that everything went well. Meanwhile, they get COVID, they become asymptomatic positive, so they potentially have an extra risk. And that's why I tend to give 2 extra points to all the patients. I have a question mark about that. But considering the risk-benefit, I think the drug is useful in this sense particularly, and it forces us again to study a little bit more on how to protect at best on thromboembolism. Thank you so much.
Thank you very much, Sergio. And again, that's Dr. Chang.
I didn't even get the name. It's an international pronunciation.
Not Georgian pronounce, right?
Ashkan.
No.
Zhang, we have a video. If you can play the video of Zhang, please. Yes. Can I see it? That was interesting. Can we have at least a video? I think it's an easy request.
Any question for the audience then?
And who is next? We have Veronica. Can we have Veronica? Also a young generation. Yeah, Veronica.
Yeah, Veronica. Golovina, yeah.
Adriana
Please,
also.
Veronica.
Dr. Maturoni is in another room. That's the other representative of the new generation. So we start with you, Veronica.
Hello, everyone. So, as you mentioned before, there are a lot of indications for sulodexide, just as chronic venous disease, post-thrombotic syndrome, and peripheral artery disease. But what cohort of patients will get the most benefits from the sulodexide, from your opinion?
What kind of patients are
Yes, what cohort of patients, like with chronic venous disease, peripheral artery disease, or post-thrombotic syndrome?
Who is going to benefit the most?
Yes, in your opinion, in your practice, how do you see it?
Well, I wish medicine was so easy to answer to something like this, but honestly, unfortunately, it is so much more complex and so much more customized. And I think it's a perfect question, particularly coming from the new generation, because as you go on with medicine, you really understand that it's all about tailor-made, like the one we have over there. So I take this chance to invite everyone to take the sonographic contest and win a tailor-made suit. I think what it has been clearly demonstrated with Sulodexide, with the SURVET trial, is that in PTS patients you might have a significant benefit in the recurrence risk. And if you take this concept as prevention of thrombosis, again, this is a major plus, in particular this moment of COVID, to stay on the safe side. At the same time, it has been clearly demonstrated and also put in the guidelines now the impact on the quality of life on the venous side. But indirectly also on the arterial side, as you said, because with the peripheral arterial disease, the walking distance increased. But if I can be biased, I think that the research we are doing in the lymphatic system are really thrilling, because the unique common denominator that you have is always the biosignaling. So how a physical force is translated into a biochemical message. And the fact that this drug can do that, as many others, but in this case with specific indications. So I always recommend to look at the grade of evidence. And if you look over there, you have MTFF, you have Sulodexide, and also the other ones where you really want to dive into the literature to really understand where they stay with a grade of evidence, because if not, it becomes more commercial and less science. Thank you. Please.
Yeah, of course.
Guys, I think I'm done, right?
I think that it may be an answer for your question that I think that the best evidence is for the patients more severely ill from chronic venous disease, for example. So C3, 4, and 6. And in my opinion, my daily practice, I have almost no doubts that those patients, this pool of patients will benefit from taking Sulodexide. And the evidence is quite nice. And I think that some points coming from those evidence were implemented into the last guidelines of European Society for Vascular Surgery, which I present here. And I think that this is the stronger pool, the stronger evidence to give the Sulodexide to those patients. But as we mentioned before, this is a very specific drug, and we also have some projects to prove that Sulodexide can be useful even from the very beginning of the disease, chronic venous disease, C0S patients or so, because we know that we've got some specific poor blood flow and some stasis of the erythrocytes at the valves, for example, at the sinus valves, and it can promote the disease at the very first stages. So, and the Glycocalyx can be crushed in those places. So if we think that Sulodexide can promote the Glycocalyx restoration, maybe we can use this drug even for these very first steps of the disease. But the most severe patients are the best pool for me. Thank you.
Thank you so much. Any comment from your side? Okay, excellent. So any comments, any question from the audience? Yes, please.
I mean, in my opinion, traditionally, when we give medications for arterial disease, they are usually in the form of antithrombotic or antiplatelet. When we give a medication for venous disease, They often now we think is anti-inflammatory. So where does this sulfodoxide come in? Does it go, how does it act veins and artery? We know it acts on the glycocalyx, but the mechanism is still not very clear. But having said that, I must also, remind us that when these flavonoids came up, we do not know the mechanism exactly. It has been, marketed as a kind of a flavotropic, decreases lymphatic edema, increases venous tone. But later on, when the research came up, we know it does act on this as an inflammatory. So I was just wondering, where does this sulfodoxide come in which mechanism exactly?
Dr. Zelinsky, do you have you on?
You are completely right that we do not know the mechanism, but there are just some signs that it can promote the restoration. As we well know, sulfodoxide contains some molecules which can be the part of the glycocalyx, but there are so many molecules which are included into the glycocalyx that only one part of it, which is delivered by sulfodoxide, is not probably the crucial one. But there's a trend. I think that there's the point, there's the moment we should maybe try to design some studies which are very difficult. I realize it, but we discussed about the drugs many times, and the conclusions are not so magnificent. So I think that such a gremium, such a meeting, is maybe the point, the moment we should start thinking practically, not only sharing our knowledge. This is very important, our experience, but maybe this is not a consensus room. The consensus room is next door, but maybe we can create such a study international. This is the privilege of this meeting, that we've got all over the world representatives, and that's the very important point. But I completely agree with you. This is a trend. This is our thought. This is our primary observation, but not true. And we should be aware of this fake news. I do not say that sulfodoxide, this is the acts for 100%, and anyone who takes sulfodoxide can have a great glycocalyx. But this is not true for now. Absolutely, this is a fake news.
Thank you for the invitation to comment on your enlightened presentation about the sulfodoxide and compression therapy. I strongly agree that sulfodoxide is an excellent choice for arterial and venous disease. In treating venous ulceration, sulfodoxide helps maintain the structural integrity of endothelial cell by the supplement of Glycocalyx, and its efficiency is well proven in clinical practice. As for the arterial cases in our center, such as arterial plaque, atherosclerosis, or patients after receiving bypass operation or endotherapy, we typically use sulfodoxide combined with aspirin and clopidogrel that enhance our efforts to prevent thrombosis and the inflammation about increased extra risk of bleeding. Thank you.